Hello, my name is Marc Baertsch from the University of Heidelberg, and I'm here at ASH 2018 in San Diego. It's a pleasure to give this overview over our phase 3 trial Relapse on behalf of our study group, the German Myeloma Multicenter group, or GMMG. The Relapse trial really is the first randomized trial comparing a salvage autologous transplant to a continuous novel agent-based regimen for relapsed multiple myeloma. As such, we randomized or recruited 282 patients at 16 trial sites in Germany and randomized them to one of two trial arms. Arm 1, the control arm, consisted of continuous Lendex at standard dose until progression, and the experimental arm consisted of 3 cycles of Lendex reinduction, followed by the high-dose chemotherapy, stem cell transplantation, and then Lenalidomide maintenance therapy until progression again. Patients were included based on key inclusion criteria of first to third relapse, of an age up to 75 years, and then of course transplant eligibility. So at data cutoff in 2017, we had a median follow-up of 36 months, and surprisingly, we did not see a significant difference in PFS or overall survival in this primary analysis. So there were certain factors that made interpretation of this finding difficult. Specifically, we had an increased rate of high-risk cytogenetics in the transplant arm, and then also there was a significant fraction of patients in the transplant arm that did not actually receive the assigned transplant. This amounted to roughly 30%. And the reasons for failing to go on to the transplant were early dropouts due to diverse set of reasons. In about half of the patients, this was early progressive disease during reinduction therapy. So the obvious question at that point was, what would the treatment effect be in patients that actually did receive the transplant? And so to answer this question, we performed landmark analyses, and these landmark analyses were performed from the time of the transplant in the transplant arm and the corresponding time point in the control arm, which was RD cycle 5, based on a similar interval from randomization to the landmark. These landmark analyses showed us then a significantly improved overall survival in the transplant arm and also a trend towards improved progression-free survival. And when we went on to look at this multivariately, including relevant established risk factors such as high-risk cytogenetics, for example, then we saw a significant association of the transplant with both improved progression-free as well as overall survival. So the other point that is important, of course, is safety. Looking at toxicities, we saw a comparable rate of higher-grade toxicities in both trial arms. On top of that, we observed increased hematological and gastrointestinal toxicity in the transplant arm, which is considered associated with high-dose chemotherapy and is kind of expected in this setting. Most importantly, we did not have any deaths during the high-dose phase, which is important because we had an upper age limit of 75 years in this trial, and this underlines the safety of this approach. So concluding from the trial, high-dose therapy at relapse is safe, and although the efficacy was lower than we had expected, there seems to be a benefit for patients that actually did receive the transplant. And then, of course, an important question is what or who might benefit the most from this approach and who may not benefit. And to answer this question, we performed subgroup analyses. These subgroup analyses were the subject of an additional talk that we gave on the trial here at ASH this year. And what we saw in these subgroup analyses was that patients with low-risk multiple myeloma, low risk according to the revised international staging system, as well as the individual components of the RISS, namely cytogenetics and LDH, that low-risk patients in these categories had excellent overall survival and had a stronger treatment benefit from the transplant than the overall population. On the other hand, patients with high-risk features in these categories, these high-risk features had a deleterious impact on the treatment effect. So patients with high-risk disease did not benefit from the transplant.